It doesn't sound like an easy study to do, first of all, just being big and multi-center, but luckily, vaginal hysterectomy and laparoscopic hysterectomies are safe surgeries and have traditionally pretty low complication rates. And so, I imagine non-inferiority is probably easier to do than true benefit, but the fact that they're all pretty safe surgeries is a great thing, but to be able to introduce a new technique and show that it's as safe and also potentially providing some improvements like decreased pain is pretty amazing for a comparison against already pretty safe and well-tolerated procedures. So that's exciting. There are things I think about with improvements, though. So in Kentucky, where I work, we have a large percentage of obese patients, probably a lot more so than in Europe. Are there benefits outside of pain and hospital length of stay for vNOTES? I think about there are patients that I just cannot operate on laparoscopically for hysterectomy because their BMI is high enough that I can't get them in steep enough T-berg to see into their pelvis. Is that an opportunity, or is that still a limitation for vNOTES?
Yeah, I think you make a good point. I think there's just 3 groups of patients that benefit specifically from vNOTES, and the obese is one of them. I'll elaborate just now. I think the other group is the patients with previous abdominal surgery. Patients have had multiple laparotomies with mesogastric low abdominal adhesions. When you address those laparoscopically, you start with an adhesiolysis. When you do them endoscopically, transvaginally via vNOTES, you can often stay below the adhesions and don't need to do an adhesiolysis. So that's a group that definitely benefits. The second group is the patient with a very large uterus. When we do a hysterectomy for a large uterus laparoscopically, we're using a manipulator. We're pushing the uterus upwards to be away from the ureters. But that way, we're always pushing the uterus towards the camera, and we have to put our camera higher and higher or more lateral. And that's a group where vNOTES is particularly good because with vNOTES, you're pushing the specimen away from your camera, you're pushing it into the abdomen, and you're actually not working in the direction of your dangerous structures of the ureter and the bladder. You're working away from them. You automatically have your blood supply at the start of the procedure as well. So I think that's where you gain most with vNOTES is on those large uteri. But the third group that benefits a lot is the obese patients. Any procedure or with any technique is more challenging as the BMI goes up. And it's the same for vNOTES. A vNOTES hysterectomy on a BMI 50 is a lot harder than one on a BMI 25, for sure. But I think the degree of difficulty doesn't go up as much as it does laparoscopically. If you're operating a very high BMI patient laparoscopically or robotically, your distance to your specimen increases with the BMI. So you're using endoscopic instruments, but your pivot point gets a lot further away from your specimen in laparoscopy, and that makes it hard. In vNOTES, the abdominal wall is as obese in the patient, but the distance to your specimen vaginally doesn't increase. There's more abdominal fat, and it's going to be in the way, and it's going to be harder with Trendelenburg, but at least your distance to your specimen from your instrument to the uterus transvaginally doesn't increase. And patients don't tend to have as much adipose tissue vaginally as they have in the abdominal wall. So I think if I have a very obese patient, and you're right, we don't have those super high BMI 70 plus, I don't see those. But with experience up to 55, 57, I noticed that it's easier to operate them via vNOTES than laparoscopically. So I never doubt if I have a high BMI patient. I know there's groups in the US that have experience with BMI 70 plus and say the same. On those patients, they prefer to do vNOTES than laparoscopy. But of course, it gets more difficult. It always does.